Good afternoon to one and all present here. Myself, Dr. Vidhi Gupta, and I would like to formally welcome you all to the 9th PTCR, that is our physiotherapy combined round, on the topic sports physiotherapy in rotator cuff injury. Thank you so much, sir. Dr. Ashwini Madhu, sir, Professor and Head Orthopedic Department, MGMCH, for being here with us and being a part of our PTCR. And also a very warm welcome to all the faculties and residents from the Orthopedic Department of Mahatma Gandhi Medical College and Hospital. Also a warm regard to Dr. Madhusudan Tiwari, sir, Dean and Principal, Mahatma Gandhi Physiotherapy College, in his guidance we have completed our successful 8 PTCRs and we have moved forward to the 9th PTCR. So with us we have our speakers for today's topic. We have Dr. Rishab Saxena, sir, PG Resident, Department of Orthopedics, Dr. Abhishek Chandra, sir, Assistant Professor, Department of Orthopedics, Dr. Aanchal Pancholi, PG Resident, MGPC, and Dr. Aashis Jain, sir, Associate Professor, MGPC. Today we would be discussing about the physiotherapy aspect as well as the overview and the surgical aspect for the rotator cuff injury, so that we could provide a patient with the best care possible. So for the first speaker, I would like to call Dr. Rishab Saxena, sir, and he would be guiding us and telling us about the overview of rotator cuff injury in sports.
Good morning everyone. I am Dr. Rishab Saxena from Department of Orthopedics, and to discuss about the rehabilitation of physiotherapy, we need to have an overview about the rotator cuff injuries. So I'll be starting with the general introduction. The rotator cuff is a group of 4 muscles. They come together as tendons to form the covering of the head of the humerus. The primary function of the rotator cuff is to provide the dynamic stability by balancing the force couples about the glenohumeral joint in both the coronal and the transverse plane. Discussing about the coronal plane, the inferior rotator cuff muscles, which comprises of the infraspinatus, teres minor, subscapularis, its function is to balance the superior moment which is created by the deltoid muscle. In the transverse plane, the anterior cuff, majorly the subscapularis, functions to balance the posterior moment which is created by the posterior cuff, the infraspinatus and the teres minor. Discuss about the muscles, the supraspinatus. It is the attachments are the supraspinous, the fossa of the scapula, and the attachment is on the upper facet of the greater tuberosity of the humerus. So we can assume the function is the abduction of the shoulder joint, and it is also to compress and depress the humeral head during elevation of the hand. The infraspinatus, its attachments are the infraspinous fossa of the scapula, and it attaches over the middle facet of the greater tuberosity of the humerus. Its function is external rotation of the shoulder joint, and it also compresses and depresses the humeral head during the elevation. The third muscle is the teres minor. It originates from the inferior medial border of the scapula, and it attaches over the lower facet of the greater tuberosity of the humerus. Its function is also the external rotation of the shoulder joint. It compresses and depresses the humeral head during elevation. The last muscle is the subscapularis. It originates from the subscapular fossa of the scapula, and it attaches over the lesser tuberosity of the humerus. Its function is internal rotation, which is the opposite of the above 2 mentioned muscles. Let's discuss about the rotator cuff injuries. It is common, they can occur at any age. In younger subjects, most injuries occur secondary to trauma or arise from the overuse of the overhead activities such as sports, volleyball, tennis, or pitching of balls. The rotator cuff muscles can also undergo muscle degeneration, impingement and tear, which usually occurs at an elderly age. Most common injuries to the rotator cuff are referred as rotator cuff tears, which are micro or the macro tearing of the muscles or tendons, which we just discussed. The second one is the rotator cuff tendinitis. It is basically the acute inflammation of the rotator cuff soft tissue, which might be following a trauma or something. The third one is the rotator cuff tendinopathy, which is chronic irritation or degeneration of the rotator cuff soft tissue. The fourth one is the impingement syndrome. It is basically the biomechanical dysfunction of the shoulder joint, which causes abnormal wear and tear of the rotator cuff soft tissue. Let's discuss about the test which we commonly use in the OPDs. The first one is the MT-GAN test. In this, we ask the patient to forward flex the arm in the scapular plane and we ask the patient to internally rotate to bring the thumb down. This basically inhibits the impingement action, and now we ask the patient to lift the arm and we try to resist it. If there is any weakness or pain on this examination, this is positive for supraspinatus injury or tear. The second one is the full can test. In this, we ask the patient to forward flex the shoulder in the scapular plane. As you can see in the diagram, there is no internal rotation. So basically the impingement movement is still allowed in this. We ask the patient to do the upward motion and we try to resist it. If there is any pain or injury or weakness, then there is supraspinatus injury. The third one is the external rotation lag. In this, we ask the patient to adduct the arm and we flex the elbow at 90 degree, and we ask the patient to externally rotate the shoulder. If there is pain, weakness or some kind of acute snapping, then there is infraspinatus injury. The fourth one is the belly press test. In this, we ask the patient to put both the palm over the anterior abdomen, and as we can see in the picture that the wrist should not flex, and we ask the patient to just push or apply pressure over the abdomen. If there is flexion of the wrist in this test, then it indicates that there is subscapularis tear. A brief overview about the radiology, just the anatomy part. In this, we can see all the the deltoid muscle, the supraspinatus muscle as marked in the diagram, the infraspinatus muscle, the teres minor, and the biceps tendon. A coronal view is also important. As we can see the retraction of the rotator cuff, majorly the supraspinatus muscle. To plan the management or to plan the further approach, there is a tangent sign. In this, we can see a line is drawn between the coracoid and the scapular spine. It is basically to assess the supraspinatus muscle bulk. Classification, Gottlieb classification, it is based on the atrophy of the supraspinatus muscle. We will be discussing it here itself. It is classified in 5 grades. The grade 1, in which the muscle belly of the supraspinatus muscle is normal. In grade 2, we can see that there is some muscle and some fat streaks are seen on the MRI. In grade 3, there is fat, but there is not 50% reduction in the muscle volume. In grade 4, the volume of the fat and the muscle is equal, and in grade 5, there is more fat than the muscle. The other one is the Pate's classification. As we can see, we discussed earlier that the supraspinatus muscle attaches over the greater tuberosity. In this, we can see that the supraspinatus tendon retraction is seen. It is classified into 3 stages. The first one is basically the proximal stump is retracted near the bony insertion itself. In the second one, the proximal stump is at the level of the humeral head, and in the third one, the proximal stump is at the level of the glenoid, or it is more proximal to it. The other classification is Ullmann classification. In this, we just measure the thickness of the tear. It is classified into 3 grades. The first one is the depth of the tear is less than 3 millimeter, or we can say just less than 1/4 of the tendon diameter. The second one is that depth of the tear is between 3 to 6 millimeter, or half of the tendon diameter. The third one is more than 6 millimeter, or more than half of the tendon diameter. There is another classification, Hamada classification, which is associated for rotator cuff arthropathy. In this, we have 5 grades. The grade 1, in which we can see a line diagram is shown just adjacent to the X-ray. So looking at the line diagram, we first see the acromiohumeral interval. In the grade 1, it is more than 6 millimeter. Looking at the right one, the grade 2, in this the acromiohumeral interval is less than 5 millimeter. In grade 3, the acromiohumeral interval is less than 5 mm, but there is acetobularization of the acromion as well. The grade 4 is further divided into A and B. In grade 4A, there is glenohumeral arthritis, but there is no acetobularization of the acromion. The AHI, the index we discussed earlier, is less than 7 mm. In grade B, there is changes of the acromion, but the AHI is less than 5 mm. In grade 5, as we can see in the line diagram, there is
My topic for this presentation is recent advancement in the surgical management of the rotator cuff tear. I am not going in detail as the topic is very vast and I am not able to complete all the surgical management in single presentation. So I will give the brief idea of all the surgical process we usually does in our routine practice. Before going into the surgery, we mostly use these two terminology for rotator cuff. One is the massive rotator cuff tear. The definition is that if the tear size is more than 5 centimeter, or if it involves more than 2 tendon, or the recent guidelines for massive rotator cuff tear if more than 2/3 of the humerus footprint is devoid of the tendon. And the other terminology we usually used for is irreparable rotator cuff. This is defined as the inability to achieve a direct repair of the native tendon to the humerus footprint despite adequate mobilization of the soft tissue. Before going into the surgery, for all patients we usually follow the conservative management by painkiller, physiotherapy, TENS or ultrasound therapy, intra-articular or subacromial injection of steroid, PRP or hyaluronic acid. This can be given blindly and it should be given preferably under ultrasound USG guidance. There is significant progress has been made in the mechanical fixation of the cuff tear like anchor, double row fixation and the equivalent technique, but there are limited options for improving biology of the repairs. Majority of the small tear heal, but the healing rate in the large tear is still vary from 20 to 90%, and the failed rotator cuff tear continue to be the major source of pain and morbidity to the patient in the long run. Before going into the surgery, various factors to be considered like the quality of the tendon tissue, the chronicity of the tear, the quality of the muscles, the mobilization of the tissue, bone quality of the humerus, fixation device and the associated pathology with rotator cuff tear. And the other factor which is not related to the shoulder but to the patient is increasing age, smoking, diabetes and the hypercholesteremia. All these factors can lead to the poor prognosis even after the surgical repair. What are the surgical options available for now? The first one is the arthroscopic debridement, arthroscopic decompression, arthroscopic or mini open rotator cuff repair, tendon transfer, patch augmentation or scaffold, superior capsular reconstruction, balloon interpositional graft and the reverse shoulder arthroplasty. Various factors to be considered for choosing the correct surgery for your patient. What is the principle of the arthroscopic debridement? The principle is to remove the inflamed tissue which is the main pain generator in the shoulder, and the tissue which is responsible for the pain in the shoulder in rotator cuff tear is associated bursitis, biceps tendinitis, adhesive capsulitis and the traction neuropathy due to retraction of the torn tendon. The next surgery is the arthroscopic decompression. It is indicated whenever we find subacromial impingement on our clinical examination, and the principle is to create the more impingement free movement of the shoulder. The arthroscopic or mini open cuff repair, it is the most common surgery used worldwide. It can be either single row or double row. It can be done either by arthroscopic way or mini open incision, and both have equivalent results. The tendon transfer, it is indicated whenever the patient is young, rotator cuff is irreparable and the severe fatty infiltration, and the pain and the main problem of the shoulder is weakness, not pain, and the prerequisite for this surgery is the shoulder should not be arthritis. Whenever we find irreparable subscapular tear, the tendon transfer we can either do the pectoralis major. Here you can see that the pectoralis major which is attached on the lateral aspect of the bicipital group, it is detached and shifted onto the LT. The pectoralis major can be transferred either over the conjoint tendon or under surface of the conjoint tendon. Both can be done. The other option for the irreparable subscapularis tear is the pectoralis minor transfer. As you can see in this diagrammatic representation, the round is the humerus head, this is glenoid, this is the coracoid, and this green tissue is pectoralis minor, which is attached on the anteromedial surface of the coracoid. In picture B, you can see that the pectoralis minor is detached from the coracoid. In picture C, it is transferred under the coracoid and then it is attached on the LT. The other option for irreparable subscapularis tear is latissimus dorsi transfer. It is nowadays considered as a gold standard whenever we require tendon transfer for subscapularis tear. Here you can see that this latissimus dorsi, which is attached on the medial surface of the bicipital group, it is detached and attached superiorly on the LT. The other case scenario, whenever we find the irreparable posterior superior cuff tear like supraspinatus and infraspinatus tear, lower trapezius transfer is another option. Here you can see this is the lower trapezius muscle and this is the humerus head. However, the tendon of the lower trapezius is not very long, so every time we use this surgery, we have to augment this bridge with either with a allograft or autograft. The other option is the latissimus dorsi transfer with or without teres minor. As we know that the latissimus dorsi and teres major, which is attached on the anterior surface of the shoulder, it is rerouted toward the posterior aspect so that it can function as the posterior superior cuff. As far as the irreparable rotator cuff is concerned, the irreparable supraspinatus tear is most common clinical finding we usually found in our clinical practice, and the surgical options are superior capsular reconstruction by iliotibial band, superior capsular reconstruction by biceps tendon, balloon interpositional graft, graft jacket, and the Regentin patch. The graft jacket, this surgery is used whenever we are not able to reduce the tendon to its footprint. It acts as a bridging tissue between the cuff and the footprint. It is costly and it is not approved in India yet. The other option is Regentin patch. Whenever the tendon quality is not good, we usually add the tendon strength by using this patch. It acts as a scaffold for new tissue formation. It is approved in India and the cost is around more than 4 lakhs. The balloon interpositional graft, it is biodegradable. It by itself it degrades within a year or two. It acts as a spacer between the humeral head and acromial process, and the function is to prevent the superior migration of the humeral head whenever we initiate the movement. This surgery is contraindication whenever there is subscapularis tear, and it is also not approved in India. The superior capsular reconstruction, it is recently developed for irreparable supraspinatus with or without infraspinatus tear. It also acts as a spacer between the humeral head and the acromial process. It is done by harvesting tensor fascial lata, which give the extra morbidity to the patient by additional incision on the thigh. It is technically demanding and it requires lot of anchor suture for fixation, which ultimately increase the cost of the surgery. And the reverse shoulder arthroplasty, whenever everything fails, this is the last rescue in the shoulder. It is, but the drawback is that it is not done in the high demand patient, and it should be nowadays it is mostly preferred in patient with more than 60 years of age. And the rotator cuff is difficult to treat. Multiple options are available presently. The techniques are still evolving. Surgery should address patient complaint, not the MRI, and the a la carte option should be used to give the best result to your patient. This is a short animated video of arthroscopic rotator cuff repair. Here you can see this is a humeral head. This is the torn tendon from the greater tuberosity. We first debride the dead and necrotic tissue. Here the subacromial decompression is also added. It is the trimming of undersurface of acromion to provide more space. Now the suture anchor is inserted onto the greater trochanter, greater tuberosity, and through this thread we repair the cuff on its footprint. Yes, sir. Okay. Thank you. And the next topic will be present.
Go ahead with the physiotherapist.
Yes. Good afternoon to Biki Kapoor sir, good afternoon to Ashwini Mathu sir, good afternoon to Madhusan Tiwari sir, and all respected faculty members and dear students. So my topic is the role of physiotherapy management in rotator cuff injury. As sir has told about the overview of the rotator cuff injury and the surgical management of the rotator cuff injury, so we'll proceed towards the management part. So as we have two scenarios, that is the conservative management as well as the post-operative management. For conservative management, that is how we conservatively manage, it has three phases. Phase 1, the rehabilitation goals would be to protect the healing tissue, to maintain pain and inflammation, and the maintain of ROM. And for interventions, the pain management would be in initial phase ice application, and we'll proceed towards the shoulder isometrics in a very low load manner. For range of motion exercises, we'll proceed with the PROM exercises of the shoulder, avoid excessive force in stretching, and we'll progress to the active assisted ROM exercises. And criteria to progress from phase 1 to phase 2 would be pain control and reduce inflammation, improve PROM and active assisted ROM, and basic shoulder movements without pain. So these are the exercises, the external rotation isometrics and the internal rotation isometrics, that would be in a very low load manner. Next would be phase 2. Phase 2, the rehabilitation goal would be to enhance the scapular stabilization and maintain pain control and gradually improve shoulder ROM. We'll progress from passive ROM exercises to active assisted ROM exercises for the shoulder, and we'll incorporate the strengthening exercises. For that, we'll incorporate first the anterior deltoid strengthening exercises. We'll begin with the isometric exercises and progress to the isotonic exercises, that will be using resistance band and light dumbbells. And we'll begin with the scapular stabilization exercises, that would be prone scapular retraction and scapular muscle co-contraction exercises. And manual therapy, for manual therapy, soft tissue mobilization, MFR techniques as indicated. The criteria to progress from phase 2 to phase 3 would be minimal pain during AROM exercises, no restriction in daily activities. For phase 3, the rehabilitation goals would be to enhance the dynamic scapular control and gradually return to functional activity. Continue with your phase 1 and phase 2 interventions. For strengthening, and progress to the isotonic exercises for the anterior deltoid strengthening, and progressive resistance exercises for the remaining rotator cuff muscles using the resistance band. Scapular stabilization exercises, progress exercises from resistance band using dumbbells, that would be row on physio ball, shoulder extension on the physio ball. And functional training. So this is the eccentric training for the rotator cuff muscles. Now we'll proceed towards the post-operative rehabilitation. So rehabilitation phases in the post-operative rehab would be 4 phases. That would be immediate post-operative phase, protection and protected active motion phase, early strengthening phase, and advanced strengthening phase, as it is a progression-based protocol. For phase 1, that is immediate post-operative phase from weeks 0 to 6, the rehabilitation goal would be maintain and protect the integrity of the repair, gradually increase the PROM, diminish pain and inflammation, and precautions that we have to take care of. Day 1 to day 6 would be passive pendulum exercises, forearm and arm muscles isometric exercises, and gripping exercises. So this is the pendulum exercises, passive pendulum exercises for the range of motion. From day 7 to day 42, that would be external rotation in the scapular plane as shown in the first video, and the internal rotation in the scapular plane more than 30 degrees. Both the movements will be more than 30 degrees, and we'll begin with the periscapular exercises. And criteria to progress for the next phase: to increase passive external rotation scapular plane for more than 60 degrees and passive internal rotation scapular plane more than 60 degrees. Phase 2 would be protection and protected active motion. Rehabilitation goal would be to allow healing of the soft tissue. Do not overstress your healing soft tissue. Gradually restore your full passive PROM. Precautions:
Week 7 to week 9 would be PROM exercises. Initiate active assisted shoulder exercises with the support of your arm. In the second diagram, it is with the use of the cane. In third, with the towel. And we incorporate the gentle glenohumeral or scapular joint mobilization as indicated. From week 9 to week 12, we'll begin with the internal rotation stretching. Is it shown in the video? That is sleeper stretch. It incorporates the posterior capsule stretching of, and it is begin in the internal rotation. Begin with your submaximal isometrics, and we'll begin with these rhythmic stabilization exercises and continue with your periscapular exercises. So in this internal rotation exercises, that will using the exercise bands, and the third video would be rhythmic stabilization exercises using the weight cuffs. Phase 3 would be early strengthening phase, that would be from weeks 12 to 18. In the rehabilitation goal would be full active ROM, dynamic shoulder stability, and gradual restoration of glenohumeral and scapular strength, and optimized neuromuscular control. From week 12 to 16, initiate the strengthening program. Periscapular, that is ITY exercises for periscapular muscles. Initiate low level of plyometrics and internal and external rotation isometrics. And for motor control, PNF D1 diagonal and D2 patterns. So in this is the periscapular muscle exercises, that is I, Y and W, and this is the PNF pattern for D1 and D2 using the resistance band. Phase 4 would be advanced strengthening phase, that would be from weeks 18 to 24. The rehabilitation goals would be maintain full, non-full active ROM, advanced conditioning exercises, and improve muscular strength. That week 18, continue with your progressive strengthening exercises continue with your exercises from the earlier phases and advanced proprioceptive neuromuscular activities, and for week 24 would be strengthening exercises, stretching, joint mobilization, and initiate with the interval sports program. So these is the multiple planar stability exercises, multiplanar stability, that would be in the sagittal and the frontal plane, and these are the kinetic chain exercises for the advanced strengthening. Now we'll proceed towards the recent advancement in the rehabilitation of rotator cuff injury. One exercise-based program is introduced, that is ISEO program, that is inhaled shoulder and elbow outpatient program. So basically it is a motion analysis based on the inertia variable sensor positioned over your thorax, scapula, and your humerus and your forearm. It is basically used to return the visual biofeedback of the humerus and scapular angles over time for the scapular humeral coordination, and exercises can require rubber band, ball, resistance band, and towel. The visual feedback is adopted, such as coordination between the angles or the variation of an angle over a time. This program integrates rehabilitation program with the use of kinematic visual feedback to provide the real-time objective and accurate evaluation of the upper arm kinematics. So for group 1, that exercises would be in sagittal plane, that is active assisted flexion and extension using Bobach ball. And group 1 sagittal plane, exercise B would be active assisted flexion and extension with a stick. In group 2, that will be exercises in this scapular plane, that is active assisted abduction and adduction with a Bobach ball. This is the initial position and this is the arrival position. And for group 2, scapular plane exercise would be active abduction and adduction by stretching a rubber band. Initial position, and that will be the arrival position. The next recent advancement would be the aquatic therapy in the rehabilitation of rotator cuff injury. Aquatic therapy basically provides buoyancy that reduce your body weight, which can restore physiological muscle activation patterns, or supportive medium, and it attenuates force and apprehension. Aquatic therapy mainly performs in a swimming pool supervised by a physiotherapist 2 to 3 times per week. Patient was asked to kneel or sit to submerge both shoulders to perform exercises consisting of progressive, passive, and active motion of shoulder for 4 to 6 weeks. Then additional strengthening exercises in swimming pool for 2 to 4 months. Shoulder elevation in water resulting in significantly lower activation of the rotator cuff and synergistic. The decreased muscle activation and during aquatic physical therapy allows for earlier active motion in the post-operative period. So this is the exercise, this is the showing. You can achieve active motion in the water aquatic therapy earlier than the land-based therapy. The main goal of the article is this. Thank you.
Thank you, Aanchal, for explaining us all about the recent advancement as well as the role of physiotherapy in a very good manner. And the students should understand one thing, that is that the main protocol should be based on the progression as a patient is showing, like phase wise, as she explained us. Now, it is a very well said thing that prevention is better than cure. So I'd like to request Dr. Aashis Jain sir to please tell us about the recent advancement and risk mitigation strategies in the physiotherapy management of the rotator cuff injury. Please, sir.
Everyone, respected Dr. Vicky Kapoor sir, Dr. Ashwini Mathur sir, Tiwari sir, Salim sir, and my fellow faculty members and their students. So it's been all about talk about rotator cuff injuries, how to manage them, but it is very important that if we can avoid the occurrence of the injury, then it can increase the health of the shoulder, it can increase the performance of anyone. So nobody wants to be in pain. We all want to be pain free. So for that, there are certain preventive measures that we can take to reduce the chance of injury, because it is not possible that I can minimize I can zero the injury, but there are steps that I can do to decrease the chances of injury. So for that, we'll talk about the injury mitigation. But first of all, let's understand shoulder health. When we are talking about shoulder, it has two components that are very important. First is the shoulder mobility, and second one is the stability. So they both go hand in hand. If one is superimposing on the other one, there is disturbance in balance between both the two. So if the balance is compromised, what happens? Either your pain will increase, or either your performance or athletic performance will decrease. So understanding the injury prevention, it has got three basic components, or it has been classified into three broad terms. First is the primary prevention, second is the secondary prevention, and third one is the tertiary prevention. The primary prevention begins when you are not in an injured state, or you are in an uninjured state. Its aim is to prevent the injury before happening. Second one and third one are when you have suffered an injury. In the secondary prevention, what we do is we prevent the small problem from growing into a bigger one. And tertiary prevention is we are preventing it from reoccurring, as well as we are facilitating the recovery process. So before going into the preventive process, we have to follow 4 steps. The first step is knowing the risk factors which are known or unknown for an athlete or the person. See, now knowing the player's injury status, it has been classified into 2 broad terms, which is context specific and one is individual specific. Now context specific can be internal or external, whereas the individual specific can be modifiable or non-modifiable factors. First is the internal factors. Context specific are the terms which it is a learning which we learn throughout our age or throughout the process. It can be the gender, it can be the trust and support networks from the person around you, your parents or your teachers, anyone. It can be situational factors, how you learn to cope up with any situation, or it can be perception of injury. क्योंकि हम जब भी इंजरी होती है, हम क्या करते हैं, उसको अलग तरह से परसीव करते हैं. Some are more apprehensive, some are less apprehensive. कोई लोग बोलते हैं चलो ठीक है चल जाएगा हो जाएगा ठीक, कुछ बोलते हैं नहीं, I have to work on this. So it is the perception of injury, each and everyone has their own. If we go towards the external context, now it can be surface equipments, means you will be playing or you will be working on different surfaces. So how well you are adapted to these surfaces, how well you are acquainted to those surfaces. Second and most important is the load application, means how much load you are applying to your body, and as well as how much your coach or your supervisor is applying load on you. It can be mental, it can be physical. The resources available to you and the fair play, means following the guidelines or the rules and regulations. Next part is the individual specific part. Now, first we'll talk about the non-modifiable factors which we cannot change. It can be the age, it can be any past injury which you have, any surgical history, any medical history. It can be the anatomy, because certain bones have different shapes, like acromion process may be different, may have different orientation. It can be your social factors, socio-economic factors, because we cannot change that in a day. Or the thing we can work on is actually the modifiable factors. First, it can be the capacity. In capacity, it can be the range of motion, it can be strength, it can be the ability to mobilize your body, it can be your agility, it can be anything. It can be your stability, it can be stamina, it can be anything. So it is a physical capacity that we can work on. Second is decision making. Decision making is when you have any injury, how do you cope up with that? Do you continue to play, or do you ask your medical team to work on that? So these are decisions and that the person has to take while playing or while working in any sport. Third one is the recovery, how well the person is recovering from any injury. It can be nutritional deficit, it can be the amount of rest, it can be sleep, it can be anything. Last one is the communication of physical status. If you have any niggle or an injury, how well do you communicate with your sports specific teams or your medical team? Do you report that or you not? If you are reporting that, then the medical person can help you. But if you're not taking that seriously, it can grow and become a bigger injury. And one note to make, the risk status will change randomly and according to the scenario. I cannot say it is always the age, I cannot say it is always the recovery. It can be anything in a specific amount. Now we'll talk about the load management. That is a very important factor for any injury. See, it is divided into three parts: the white part, the green part, and the red part. The white part denotes, the x-axis denote the acute to chronic workload ratio. Acute means within 7 days and chronic means say minimum of 4 weeks. And this, and the y-axis, it denotes the chances of injury. So if you can see the graph here, it is increasing in the white zone, decreased in the green zone, and again increasing in the red zone. So we calculate the chronic to acute workload ratio. Suppose a bowler or javelin thrower can throw a javelin, is throwing a javelin for 100 javelin throw, he is doing 100 javelin throws in 1 week. Now he has been doing that in the last 4 weeks. So, but in the next 5th week, he starts throwing approximately say 150 javelins in that week. So the ratio increased from 1 to 1.5. That can cause a possible injury. Similar thing can happen if he is reducing the amount of load on his body. The second part is the movement screening. I can give you the example for that. Like last year I was working with Rajasthan Cricket Association. So what we did is we devised a program. We screened everyone, every player, from either it was Ranji Trophy or either it was 23, 20. We scanned and screened everyone to find out what is the possibility of injury. And we did that we did functional assessment. First, the posture. Second, his strength, his movement pattern, his stability. And yes, we did some special tests. These are a list of few special tests that we did. Range of motion in different angles, strengths, pectoralis minor strength, tightness, Hawkins kinetic impingement test, O'Brien test. We did all these things. So we were able to find out that these players are prone to the injury. These are susceptible players. So we worked on that so as to decrease the chances of injury. These are few of the videos which we did. Shoulder internal rotation, shoulder external rotation, range of motion, impingement test, O'Brien test. We also tested the strength in external rotation and internal rotation strength in 90-degree abduction. Third part is devising the strategy for primary and secondary care or secondary preventive strategies. Now, function was that to focus on strengthening of the shoulder muscles first, second the improving flexibility, third targeting on the specific stabilizers, fourth proper warm up and cool down strategies. We also have to work on the correct formation, which is very important. If you are not doing a exercise in a correct form, it can not give you the result which you are waiting. So we need to have a correct execution of exercise to prevent any injury. It should be in the presence of any qualified health professional. Gradual progression and adaptation of exercise program should be there, no sudden increase in the load, and regular monitoring and feedback of the technique. You can use Delphi method for that. Now, secondary prevention exercises, these are rehabilitation focused exercises to prevent future injuries, and we have to work in collaboration with your healthcare professionals, trainers, coaches, and personalized person for that. All the programs meant, all the exercise plans made are individual specific. These are not, it is not a recipe that we can give it to everyone. It should be tailored according to the individual's need. Last is the implementing program. These are few studies which shows that in softball players, shoulder incidence was more in females because of strength issue, and in males it was more of because of the scapular kinematics issue. In pitchers, 17% of pitchers suffered shoulder injury, 7% of them required surgery, and it was all because of GIRD, glenohumeral internal rotation deficit. FIFA, they developed a FIFA 11 shoulder program which helped in reducing upper extremity injuries among soccer goalkeeper players. This is the FIFA 11 shoulder program. Now, general principles for the preventive measures are the exercise should be conducted in sports specific position, because if I am working on the javelin thrower, I will not be focusing on my running technique. I will be, but not as much. Exercise should be it should cover multiple joints. It should cover the whole kinetic chain, not a single individual joint. It should be implemented at least 2 times per week, and it should require a minimum of your equipments, and it should take approximately 10 to 15 minutes of routine for your preventive measures. And exercise targets are rotator cuff imbalances, shoulder girdle strength in multiple planes, dynamic trunk control and core strength, and controlled deceleration of the arm. Examples are high plank walkout for scapular stability, thoracic rotation tees, Y balance, multiplanar shoulder stability, eccentric external rotation loading. Now, some of the do's and don'ts which we have to follow for preventing any injury. First, do develop an injury reporting system where person can report your injury to you. Second, we mark the injury as a flag. It can be yellow, it can be red, it can be orange, it can be green, it can be blue, anything. So we are programming devising a strategy so that person can report that to you, and you can strategize what action to be taken. Now, do establish a trust relationship between the players and encourage them for communication. So let the person know, educate them, so person can report the problem to you. And do create a communication pathway between medical performance and technical coaching team, so that player can go through a proper channel. He does know how to report and who to report to. And certain don'ts are that we do not ignore any of the reported problem or injury. Second, we do not let the niggle decide it is going to turn into an injury or not. Third thing is we do not stop someone from playing if he has got a niggle. We examine that, then we decide he should play or not. Last one is we do not share any of his personal information to anybody. Lastly, the injury prevention program is composed of 5 E's. First one is engineering. So what we do in engineering, we devise a controlled environment where the player can perform or can work on his exercise where the chances of injuries are less. Second, reinforcement or enforcement, where we advise the player to go through all the guidelines and rules and regulations of the game. Third is the economics. So we do not want to enforce any monetary problem to them. So we'll work on minimum equipments so that there is no financial burden on the player. Fourth is education. We educate the person to report each and everything and to understand the importance of injury prevention. Last one is the exploration. So we continuously keep on devising new strategies, new plans, how to implement and how to plan a task specific prevention program. So in conclusion, I'd like to say preventing rotator cuff injuries is crucial for athletes and working person. And by understanding and assessing the individual needs, we have to decide when we have to devise his plan of care. And emphasizing on prevention not only enhances performance but also promotes his long-term shoulder being. So a little effort from today can save you from the tomorrow's pains tomorrow. Thank you very much.